What if Alzheimer's, addiction, migraine, anxiety, even burnout are not separate diseases but different expressions of a nervous system that has lost its ability to regulate itself? Hello, it's Dr. Josh with Alzheimer's Breakthrough. Welcome back. Today, we're joined by Dr. Kyle Bills, a neuroscientist, clinician, and innovator bridging neuroscience, AI, and clinical research to transform how we understand brain health, mental resilience, and neurologic recovery. Dr. Bills holds a PhD in neuroscience and a doctorate in chiropractic medicine and currently serves as the Associate Dean for Research at the Neuronova College of Osteopathic Medicine. He's published extensively on topics ranging from dopamine physiology, addiction neuroscience, migraine pathophysiology, traumatic brain injury, and non-pharmacological neuromodulation techniques. His research lab focuses on chronic migraines, generalized anxiety, substance abuse disorders, and metabolic dysregulation, all within a lens that combines basic science, clinical insight, and translational impact. At Neuronova, he leads scientific innovation and clinical strategy for technology designed to support brain regulation and healing without drugs, including their signature non-invasive neural stimulation platform. Dr. Bills, thank you so much for joining us today.
It is my pleasure to be here with you.
Awesome. So let's get started with what is the name of your device and how in the world did you come up with it?
Yeah, absolutely. So, boy, the current name is Neuronova. So that's kind of the name that we've gone with this. And at this point, it's a device that you sit on. And I guess the quick history of it is years ago, I was working in a pain management clinic actually, and worked really closely in California with the workers' compensation medical unit for the state. And so we would have all kinds of patients. Back in those days, this was the Wild West still of pain management when opiates were like candy, right? And so we had a lot of patients that had been using opiates for a very long period of time. And as we tried to treat some of the underlying pain disorders, and it was time to start kind of coming down off of these long-term opiates, that's a challenge. And it's a very anxiety-filled experience. If, anybody that's experienced that knows. I mean, I had when I was in school, I still recall a professor that was trying to describe this process of coming down off of these addictive substances. And the analogy was, if you remember when you were a little kid and you were swimming in a pool and somebody would hold you down under the water, maybe you're playing for a minute, but then it turns into you're trapped under the water, and that panic that you experience to get to the top and get a breath, and you take swings and do whatever you have to do to get to the top of that water. And that was their analogy. They said, that's the drive that someone who's in the throes of addiction and withdrawal, it's that intensity that their body is screaming to go and find that again. And so, we were really doing our best to try to help in that process. And we started to make this observation that these individuals that were trying so hard to whittle down on these opiates, when they got physical interventions like manipulations or physical therapy modalities, they would report that their anxiety was reduced. Mm-hmm. And to be honest with you, we didn't really know what to do with that other than kind of, we go, well, I'm really glad. What a great thing. That's wonderful. Well, it wasn't until we kind of connected a bunch of us as colleagues together, and everybody kind of reported the same thing. And so that was curious enough that it kind of led us to sit down in a brainstorming session and kind of hypothesize, well, maybe there is a neurological pathway that's driving some of this. And so that kind of led to working with some other amazing colleagues when I was at Brigham Young University, Dr. Scott Stephenson in particular, and we sat down and kind of hypothesized that perhaps there's a peripheral nerve pathway that will travel up through the spine, and maybe it doesn't just go to those normal areas that we know about. Like we know about the thalamus and the somatosensory cortex, which is kind of what you normally would imagine from physical stimulus. But maybe there was another pathway that hadn't been described. And so we actually started with spinal implants. And so we're surgically implanting stimulation devices into the spinal columns of rodents. And then we could put electrodes down into the different parts of the brain where we could record individual neurons. And then we could stimulate the spine, and then we could record the changes that took place in the central nervous system. And honestly, a little bit to our disbelief, that first time we fired that up and we stimulated, and we were recording in this dopamine system. We call it the mesolimbic dopamine system. It's kind of the midbrain and the striatum area and the limbic system, and there's these big dopamine neurons. And next to the dopamine neurons are these smaller nerves that are called GABA neurons. And GABA neurons are the ones that slow down the dopamine neurons. And so we put an electrode down into the brain, and you kind of slowly move it down, and you're watching this little window of an oscilloscope where you can see electrical waveforms, and you're kind of hunting until you find just the right nerve. And so we found just a perfect GABA neuron, and then gave that stimulus in the spine. And boy, we watched as that GABA neuron just depressed its firing rate. And honestly, we sat there kind of mouth agape for, I don't know that we said anything for like 10 minutes. We just kind of stared at it thinking, is that real? Like, that can't be real. That's not supposed to do that. There's no pathway that goes there. And so over the course of a couple of weeks, we repeated these experiments, and it just kept depressing these GABA neurons. So
to be clear, through stimulation in the spine, that's how you were.
Yeah, purely with spinal stimulation, we were getting depression in this dopamine circuit in a part of the brain that to that point was totally unrelated to this.
Wow.
But it's very related to addiction and anxiety, behavioral health. It's related to learning. It's related to being able to change. It's related to so many different, some aspects of cognitive processing and perception, like very important, but not seemingly for those pathways in the spine, right?
Yeah, let's unpack that for the audience a little bit. So GABA is a neurotransmitter that helps calm the brain down. It helps lower the electricity. If you ever had trouble going to sleep, it could be that you don't have enough GABA calming the whole circuits down. On the other hand, dopamine is one of the rewards neurotransmitter. And as you mentioned, people with addiction might have low dopamine. And what's interesting is that there are a lot of activities that increase dopamine, things like sex and gambling and exercise. All those things will increase dopamine. And from my study of addicts, normally addicts will have much lower levels of dopamine, and they're actually doing activities to treat themselves, to increase the amount of their dopamine. So what I find fascinating is, from this earlier research, you actually found a way through spinal electrical signaling to change the neurotransmitter levels in the brain. Is that right?
That's right. And maybe one element of kind of additional background here is dopamine is an interesting neurotransmitter because, when you hear about dopamine just in the media or, even on, a variety of places, dopamine is kind of, it's broadly mischaracterized. A lot of times people think of it as a neurotransmitter that makes you feel good. And that's not necessarily so. Dopamine is actually, it's a reinforcing neurotransmitter. And so you can have a painful stimulus, a very unpleasant stimulus, and it'll produce a dopamine release in the brain. And you can have a very pleasurable stimulus, and that'll produce a dopamine release in the brain. But the curious part of dopamine is that dopamine gets released when you encounter something that you did not anticipate or something that was particularly potent. And the brain releases it so that you can kind of lock in the circumstances of that, so that in the future, when you encounter this, you'll better predict that it will occur. So it's almost it's a built-in circuitry of change and learning and adaptation in some ways. And you have some drugs of abuse that hijack that system, and they'll produce euphoria and pleasure through a complex interaction of multiple neurotransmitters. And they'll do it in the context of also producing a massive release of dopamine so that you reinforce that experience. And it leads to kind of this drive to go after that same experience again.
And what I would say as an aside is, if anyone listening to this has neurologic issues, whether it's Alzheimer's or migraines or chronic pain syndrome or depression, what have you, if you have a brain disorder, I think it makes sense to actually check your neurotransmitter levels. So the routine test that I will get is the urine neurotransmitter levels, and then I can help tweak it. For example, if the dopamine is low, there are supplements, essential oils, medications I can give to increase dopamine. But the reason I'm interviewing Dr. Kyle Bills here is he actually has a device. So instead of using a pill or a potion, he actually has a device that you sit on that, from my understanding, can actually increase dopamine. Is that what you've finding so far?
Yeah. So I guess maybe I'll bridge from where we left off and cut
Please.
over to humans here for a minute. So yeah, that's correct. Yeah, that is correct. So so we I guess I'm jumping right back in it. We were characterizing those GABA neurons, and maybe to make a really long story a little bit less of a long story, we shifted over and we were able to record then the dopamine neurons, and found that with that spinal stimulation we could excite the dopamine neurons. And then we went and we actually extracted the fluid around the ends of the dopamine neurons so we could measure the actual neurotransmitter levels, and found that indeed with that spinal stimulation, we could increase dopamine levels over the course of about an hour to about 180% baseline. Now, to give some context of what that means for everybody listening, I suppose the context would be, if let's say, for example, somebody took a drug of abuse, and let's say cocaine. Cocaine would produce maybe around a 300% baseline increase in dopamine levels. Methamphetamine would produce about 1,000% baseline.
Don't forget caffeine.
So yeah, you've got a variety of those things, and caffeine's a unique one for a number of reasons. Maybe that's for a different topic, but that
Okay.
is a curious one. But yeah, you can have, sex, alcohol, your favorite food. You've got just a variety of different baseline increases in dopamine that come from that. 180% is more in the physiological range, meaning it's more akin to what the body, it's a hefty increase that's normal and natural that your body would go through in order to rewire itself, which is very different than a shot of methamphetamines and 1,000% increase in dopamine. That's going to be a pathological increase in dopamine, right? So anyway, that's a quick aside. Now, as we found that we could increase those dopamine levels, that the next phase was measuring whether that would translate into behavioral changes. And so I'll make that brief, but we were able to actually measure those effects, and show that it indeed had those behavioral effects. Now, the next problem, though, is so far we had a surgical implant. And that's not really what we wanted this to be. We didn't want this to be an invasive device that required a $500,000 neurosurgery in order to help, for obvious reasons. That would really limit the utility of it to the worst of the worst possible cases in order to justify such a risky.
But to be clear, there are devices used in humans, spinal nerve stimulators. So there's a place for it. But you're exactly right. If taking something to the masses, the less invasive, the better.
That's right. And I thank you for that caveat, because I didn't mean to be critical of that. But what it does is, in essence, the more invasive it is, the more it limits the mass availability of the device. And so that was our rationale for wanting this to be a non-invasive device. But the trouble was the frequency that you have to stimulate it at to get the change in dopamine is about 80 hertz, 80 to 90 hertz. Now, if you're not familiar with what that means, in terms of mechanical stimulation, that's really fast. If you've ever stood on a vibration plate, for example, they're normally going somewhere between like 30 and 50. And that feels pretty fast. But the problem with 80 to 90 is that it moves so fast that it doesn't create very much displacement. Mm-hmm. And so you can't just create a device that vibrates at 80 to 90 hertz and then put it on someone's spine, because it doesn't produce enough tissue displacement. And so the actual wave of mechanical vibration doesn't get deep enough into the spine where all those little nerve endings live. And so that led to another group of us that got together, and we worked with some other colleagues at the university, and came up with a workaround, which was to create two different vibrational frequencies that are offset. And if you offset two vibrational frequencies, and then those two vibrational frequencies travel and combine with each other, the combination produces a third frequency. And that will cause what we call a beat frequency. And you can get beat frequencies that will produce harmonic multiples. So now we could produce a lower frequency that does produce displacement, that would produce within the spine harmonic multiples where we could embed higher frequencies within it.
Got it. And just interrupt you for a second. And just basic physics, 1 hertz is it 1 cycle per second?
That's right. 1 cycle per second would be 1 hertz. So now we're talking 80 hertz, 80 cycles every second.
That's pretty fast.
Pretty fast. Yeah, absolutely. And so, we actually did some testing on a you could even do a little handheld device. If you turn the intensity of 80 hertz up high enough so that it would produce enough displacement, it turns into a bone saw of sorts. So we thought it's not going to work.
That's not going to work. But the solution you found was actually to use two different waves of different frequency, and then they somehow, instead of interfering, they actually work together to form a third frequency?
That's right. As they interfere, they produce that third frequency. The interference of them produces the third frequency. And if you have somebody sit on a device where under each of the sides of their backside, into the two sit bones down there that are called the ischial tuberosities, that's kind of the butt bone down there that you sit on. And so you got one source under one and another source under another. And one wave travels up through one side of the pelvis and the other travels through the other. And they meet in the tailbone in the spine, and it produces that harmonic within the spine, so that we can get a safe, gentle, effective stimulation that hits the right frequencies in there. So once we had that, we tested it in a higher order mammal, which is college students. We went after the most anxious time in life for a college student, which is finals time, and gathered some data that showed that, man, this was significantly reducing anxiety levels in these college students. And so those data we submitted to the National Institutes of Health in an attempt to try to take this to treat opiate use disorder, and they funded that research, and we completed a phase 1 NIH-funded clinical trial, and then that was done inpatient, and found that indeed we could significantly reduce anxiety. We could improve the rate at which someone falls asleep, and we can improve deep sleep, and we could improve neurocognitive profiles simply by adding this stimulation on this device, this chair, into the standard of care.
Got it. So non-invasively at 80 hertz. How long would these college students have to sit on the chair for?
10 minutes a day, 5 days a week. So pretty simple, pretty easy. And so it wasn't particularly onerous of a task, and it was pretty exciting each step of the way, watching this kind of keep working. And so now the device is out in over 100 clinics, being used to help to improve outcomes in a variety of different cases that can utilize dopamine to enhance things.
That's awesome. And just so we're clear, what if you sit on this device for 10 minutes for many days in a row, what you're doing is you're increasing dopamine. And are you doing anything to GABA, or is it mainly dopamine that you're affecting?
So yeah, when we measured the actual neurons in the preclinical studies, it depresses GABA. Now, there's going to be, I think, a few viewers that'll say, "Wait a minute, depressing GABA? Don't I want more GABA if I'm trying to calm down?" And you think, well, it depends. GABA is an interesting neurotransmitter because in some that's accurate. But that doesn't mean it holds true in isolated circuits. So for example, if you depress a GABA neuron that happens to go to another GABA neuron that happens to go to a dopamine neuron, then the effect of calming down the nerve that calms down the next nerve, the functional effect is that you increase the effect of the third nerve. And so in the case of this particular circuit, the effect of depressing GABA neurons is actually excitation of the dopamine circuit.
Which will increase your dopamine level.
Which will increase your dopamine level, that's right.
That's awesome. Yeah, it's obvious the brain is super complicated, different types of neurotransmitters. There are different types of GABA receptors. There's GABA A, GABA B. Do you know what type of GABA you're dealing with?
It does seem to affect both multiple types. So we've not seen one that it didn't as we've done some of the testing. In that circuit, I need to always preface that, clearly we've not put electrodes in every single circuit of the brain. So we've done most of our testing in areas of that, the ventral tegmental area, the nucleus accumbens, and portions of the amygdala.
Very cool. And I think one of the other keys is when you're sitting on this device, you actually have to be sitting upright. Is that true?
That's correct. Yeah. So the spine is an interesting organ. There's a really high concentration of these mechanically sensitive receptors in the spine. And you've got some of them in the low back, the lumbar spine, and then you've got even more of them in the mid spine, the thoracic spine, and then you've got the highest concentration in the neck spine, the cervical spine. And because these receptors in these spinal joints, they're meant to be weight bearing. And pressure and weight actually are part of what activate them. And so when one's in an upright position and they're sitting on this device that produces the mechanical displacement, that allows that wave to travel up and hit all of those areas in the spine that have the highest concentration of those nerve endings to kind of maximize the effect.
So here's a question for you. How do we know from your research, how do we know that the effect is on the spine and not? Because I can imagine when you're sitting on a vibrating chair, it's not just your spine is vibrating, right? Your head's also vibrating. How do we know that there aren't mechanoreceptors? I mean, we know there are mechanoreceptors in the ears, in the inner ear, but how do we know it's not an effect actually within the skull and not just the spine?
Great question, and it's a very good question because we've actually been finding over these last years, there are mechanically sensitive aspects to nervous tissue and even to portions of the cytoskeleton within neurons. And so their mechanical and vibration is way more important than we ever understood. And so this is a really important question. And so we wanted to know that same thing early on. And so one of the things that we did is you can methodically go through and you can do ablation studies where you actually knock out certain ascending pathways and then isolate where the stimulation is provided so that you can watch when the effect disappears and really whittle this down to, okay, we know it's, and in this case, what we know, and forgive the jargon here for a second, but we know that there's certain subtypes of deep spinal joint mechanoreceptors like subtypes of Pacinian corpuscles and likely some Meissner's corpuscles that activate through the dorsal column medial lemniscus, and then they travel up towards the thalamus, we think down through the lateral habenula, and then they project back into the nucleus accumbens and then into the ventral tegmental area.
Right, and so, those are all parts of the brain.
Parts of the brain.
Yeah.
And that's an annoying way to say that. Forgive me for just spouting off a bunch of brain regions, but I think it's a little bit important just because there's a method to the science of it where you say, okay, well, what happens if this pathway can't fire? And then you say, well, it still works. And then you say, what if this one can't fire? And then you go, oh, it doesn't work anymore. And so you methodically over the course of a year, you map out the pathway so that you know what it is that's actually producing it. So it's a tedious, long, months upon months and years of slowly isolating circuits before we would ever move this into anything that would approximate a human.
That's awesome. So one question that comes to mind is, especially if you're talking about addiction or dopamine, people are like, oh, you want me to sit here for 10 minutes, but you know what? If I get more of a reward, forget 10 minutes, I'm sitting here for 10 hours. What happens when someone does more than 10 minutes?
Yeah, great question. So the effect itself will kind of, you'll actually hit the peak of your experience on the chair generally after 5 or 6 minutes, actually. And you're not actually going to get an increase in effect by just sitting on it for 20 or 30 minutes. And so what generally will happen is someone sits on it is about 5 to 6 minutes in. The pretty consistent report is that people will just kind of sense this little letdown where you'll actually watch their posture kind of go, and physically there's a little bit of a release, and they'll report that their thoughts start to calm down. So that kind of, the cycling of thoughts and the rumination, and I'm worrying about this and my schedule this, and I hate sitting here because I got things to do. About 5, 6 minutes in, you just watch people kind of go, and they just chill. So we've actually got this, this device is being used in a couple of inpatient adolescent psychiatric hospitals. And some of them kind of colloquially have actually called it the chill chair. That's not what we call it, but that's kind of what it's been come to be known as in some of these environments, because they'll kind of experience, this little bit of a calming. And so there's not really much of a reason to sit on it longer than about 10 minutes. You won't necessarily get, it doesn't produce a high in the sense of like a pleasurable reward. It's more of a calming effect and a focusing effect.
Got it. What about someone who has multiple times of stress throughout their day? Is there any downside to doing this multiple times a day?
Great question. So some of the studies we did early were to find out, well, what happens if we give the stimulation and within, a couple of hours it returns to baseline, then we immediately give another stimulation. So it turns out that to make it a simple answer, you don't actually need to. You get the effect by sitting on it for about 10 minutes a day. And what will happen is the first time you sit on it, you will notice that the effect of it wears off after about 2 to 4 hours. After about the first week, you really start to notice that you start the positive effect of it starts to stay between the sessions. And after about 2 weeks, we kind of hit the point where we're kind of starting to reset a baseline.
That's awesome. Another question is, it seems like right after this happens, you calm people down. Well, what about people who have trouble getting to sleep? Would it make sense if you're going to do this once a day to do it right before you go to sleep?
Yeah, great question. So it turns out, we would call getting to sleep, we call it, the time to get to sleep is called sleep latency, right? That's kind of the scientific term for that. So it turns out sleep latency is actually a dopamine dependent process. Dopamine is integrally involved in sleep latency. And so we actually published a study a couple of years back where we used this type of stimulation with a technique called polysomnography, which is kind of it's the standard way you measure what's happening within the body and brain when you're doing a sleep study, for example. And so we measured this effect with polysomnography and found that this actually would significantly improve sleep latency. And then since then, we've been gathering lots of data with wearables, so we can watch sleep staging, and we're finding a pretty significant improvement in the quantity of deep sleep specifically.
That's really that's really important for my Alzheimer's patients, because what we're finding is patients who don't get enough of the N3 deep sleep have higher risk of getting Alzheimer's. So from your studies, does this device affect the N3 deep sleep?
I'll say, I'm going to use the word preliminarily, because we've gathered lots of data on deep sleep,
but
we haven't published it yet in a peer-reviewed journal. And so I'm always, as a scientist, you always say, well, we'll get it through a proper peer review before we stand up and shout. But we do have quite a bit of data that is highly suggestive that yes, indeed, we are seeing a pretty good trend of improvement of deep sleep quantity. We have published some evidence showing the sleep latency, and we think in part it's because it calms down errant thoughts and helps to put someone in a little bit of more of a sedated state that allows them simply to fall asleep faster. And the next step of that is that does seem to be translating into their ability to get into kind of that deeper sleep staging.
That is so exciting. Wow.
Yeah, it is. It's very promising. We are very excited about that. And we're still gathering a bunch of data, and we're excited to write that up and put that out there and let that be scrutinized by the broader community a little bit and make sure we've done that right. But the evidence we have so far is exciting.
Got it. If I can ask about, because some people are going to be thinking, well, why do I need this vibrating seat? Can't I just take a vibrator, something that's going at 80 hertz? I mean, can you buy a vibrator at 80 hertz and just put it out against your spine as an example?
Yeah, great question. And honestly, that was our first thought. We thought, well, great. That's the easiest solution we have here. We don't need and the trouble is that 80 hertz, because it's so fast, if you put that down onto the spine, it won't produce enough deep movement to activate those deep receptors. And if you find a device that you can crank up high enough so that you could just do it straight like that, the power and frequency is such that it would risk breaking your bones.
Oof.
So
what about?
I guess we abandoned that because it's dangerous and it's not viable.
Got it. What about like an ultrasound probe? Can you set an ultrasound probe at 80 hertz?
Yeah, that's another really great. I love these questions. Actually, this is fun. So we thought, boy, this could be done with electrical impulses, maybe with ultrasound impulses, right? There's a variety of ways to depolarize neurons. Ultrasound's a curious one. Ultrasound, it's you can get some centimeters in depth. Some of the receptors we're looking at are deeper than that, and so you start risking a significant amount of heat production if you try to crank it up and try to get the depth that you might need there. So that was problematic.
Okay.
And then there's technologies like TENS units, obviously, and interferential currents that have been used for years to produce different effects. Yeah. We know that certain frequencies of electrical stimulation can produce different types of opioid release, natural opioids in the body. But the trouble there is if you want to send a current down where those nerve endings live, you've got to run it right through the spinal cord.
Ooh.
Generally, a big blast of electricity through the spinal cords, you could do it, but you might not be able to walk for a few hours afterwards. That was a suboptimal solution.
Wow. Okay. Oh, so let me ask you this. So you've got the device, it's commercially available now. How do you see people using it?
Oh, that's a great question. There's a interestingly, as a researcher, I always get a little anxious and have to go sit on the chair myself because we've got so much data coming in right now that there's not enough time to analyze everything. And so we've got a lot of anecdotal stuff that's coming in of people using the chair and saying this and this and this, that we're still trying to really catch up on some of the science in some ways. But we do have quite a few clinics that are utilizing the chair, especially in behavioral health and neurocognitive outcomes. So because you get an increase in dopamine, dopamine is a critical neurotransmitter in order to change. And so we have a lot of behavioral health and psychiatric type facilities that will actually have somebody sit on the device and then go into a session where they'll engage in cognitive behavioral therapy, for example, and really kind of enhance the outcomes that occur with those types of things. We've got facilities that, and this is from a doctor's perspective for a second, but we've got some facilities that utilize it to help when someone's trying to make a lifestyle change, implement that way. We've got some that use it for helping with insomnia and sleep, and others for anxiety. And then we've got a variety of individuals that use it at home for anxiety, for sleep, for meditation. We've got an increasing number that use it. They'll sit on it, then they'll engage in mindfulness and meditation, and find that it really enhances their ability to kind of get into that meditative zone. So a lot of use cases right now that we're and then probably a bunch others that I don't want to mention because we don't have enough data on them yet.
Sure. Well, which leads to another question. Is there any type of person who should not be on this? Are there contraindications like pregnancy or pacemakers, or if someone happens to have an electrical stimulator in their spine? I mean, who should not be using this device?
Yeah, great question. So certainly we've definitely not tested this in any type of a pregnancy population. And so we'd always recommend that that's probably not good until otherwise proven, right? I think that's pretty safe with most interventions. You kind of say, don't do that while pregnant because we just don't know, right? And that's fair. And we just don't know. Because it's a mechanical stimulation, that's really where we would look at that and say, well, you're going to be sitting upright. And so if you have an actively, spasming muscle, right, in your backside, the big muscle in your backside, like a glute or a piriformis, you probably don't want to sit on any chair directly. And so, we'd recommend things like that. And so, and if you've got a fresh wound, or you've got, a fresh implant or something like that, clearly we'd say probably not a great idea. So really any contraindications would be things that we would contraindicate with gentle vibrations. We'd say probably we'd hold off there.
That makes sense. What if someone has like an implant in their spine, or, I mean, obviously someone's had recent spinal surgery. No, don't use this. But what if you have a spinal implant?
Yeah, we've definitely, this is that's not a use case where we've actively tested it. And so we'd always kind of say, let's err on the side of caution, in any of those particular cases, especially if, say it's a spinal stimulator implant that has very, very precise connections and things like that. Probably better not to do anything that's particularly jarring, to risk displacement of any of those fine wires.
Cool. What about a pacemaker? Those are not uncommon.
Yeah, a pacemaker. We've definitely not run any clinical trials to see the effects on the mechanics of a pacemaker. So I would say probably we'd err on the side of caution and say we'd probably want to hold off
for now. That makes sense.
Yeah.
What about, and this sounds like kind of out of left field, but you mentioned vibration. I know one way to potentially magnify vibration is to do things in water. Have you studied this instead of on land? Tried this in a swimming pool or something like that?
Instead of on land, at sea?
Yeah.
Yeah, that's interesting. So we actually did build some prototypes actually in a variety of ways. One of the methods that we looked at was actually so if you take sand and you place underneath sand the ability to flow air through it, you can actually liquefy sand. Not actually liquid, but it turns into a fluid as sand because air is passing through it, right?
Kind of like quicksand in a way.
Exactly. Yeah, precisely. Except here, you do it with air that's passing through it. And so we did run some experiments where if you liquefy sand with air, someone will sink down into it, and then you can pulse the air at frequencies that would produce the compressions in essence, and looking at it that way. It was pretty messy though. It was actually fun. And a lot of people, I mean, it was pretty enjoyable in that sense, but it's probably not very consumer friendly or great for a doctor's office because you have to clean it up quite a bit. Um, but it's great if you're interested in something fun. We also looked at it in some other mediums. And so, some of the early prototypes in kind of that, having it go through a different medium where we built a device it had water in it. And then are you familiar with Orbeez?
I don't think so. No.
So they're these little kind of dehydrated gel-like pellets. And if you put them in water, they bloat up. And then they have these little toy guns that you can shoot these little Orbeez out of. And so we actually filled up a basin with water and Orbeez, and then allowed us to put those vibrations through the water while someone was sitting in the middle of it. And so that was another interesting use case that we're still kind of exploring on the side here as potential. The trouble is it's just a far more fixed device that's harder to move because of the water.
Wow, that's fascinating. And how the current device, how is it powered? Do you plug it in or
just plug it into the wall? Yeah. Interestingly, the water and Orbeez, it produces another kind of a skin sensation. And the reason we actually started to explore it were some early experiences as we worked with some of our friends, young friends that were dealing with severe autism. And they actually found that the combination of that frequency with the that skin sensation was very calming and soothing and helped them focus better. And so that's actually why we've been pursuing that one a little bit, but that's much earlier on in development.
That is fascinating. So I know historically you started off with TBI, traumatic brain injury. Has this been used on any patients after concussion? And I also know that some of the Alzheimer's patients I see, one of their risk factors, root causes of the Alzheimer's is prior brain trauma. So I'd love to hear your experience with the device in that context.
Yeah. So yeah, we have done quite a bit of work with traumatic brain injuries, and we've done we've got a clinic here at the medical school where we do have a substantial portion of post-concussive syndrome cases that we work with. And we do a kind of a combination of some structural studies where we look at brain structures with MRI and a variety of imaging modalities and EEGs, and then kind of neurocognitive mapping exams where we can look at functional cognitive domains, and then move through targeted cognitive therapies to try to enhance some of those domains. And so that kind of background helps lead up to this. But one of the challenges you see with trying to rewire and help certain brain regions kind of refunction a little bit is anytime you're really trying to change perception in the way the brain functions, dopamine's involved in some way. And so we have used it in order to have someone sit on the chair, elevate those dopamine levels, especially before we go into some of the neurocognitive rehab. We actually found in our opiate clinical trial, there were 3 cognitive domains in particular that in this study we published about a year ago, but 3 cognitive domains in particular that simply by sitting on the chair, they were enhanced. It was mental rotations was one of those. There were some alterations in kind of spatial short-term memory, but also in an area called that cognitively is called response inhibition, which is kind of that area that when there's a distraction in the room, let's say you hear a little bit of a noise, response inhibition, that's the function of the brain circuit that lets you filter out distractions and stay focused in the midst of distraction, or to not react when somebody, let's say somebody posts something you don't like on social media. And there's that urge we all have to respond and say something, and we just can't let it go. Well, that's one of the functional outcroppings of kind of the measurement of response inhibition. And so,
right. And is that in the anterior cingulate part of the brain? What part of the brain are we talking about?
Yeah. So the anterior cingulate is absolutely involved in that. Entorhinal cortex and a few others, prefrontal cortex. Some of these complex areas definitely are involved in that circuitry. And interestingly, stimulation with the chair, significantly improved function in that circuit, just from sitting on the chair, which was a curious one, and one we're actually doing more studies on right now to try to understand a little bit better. But that was an exciting little discovery, because that's an important circuit for behavioral change and neurocognition, bro.
Definitely, and I see low dopamine levels in many patients with ADD or ADHD. Have you studied it yet for that condition?
We have begun, yeah. So that's another one of those where we've got some great data that we've not published peer reviewed yet, and so I always just, the science side of me always wants to throw out the caveat of, we'll talk about what we're looking at, but then we'll belay final judgment until we get a paper out there. But yeah, we have absolutely been looking at it in that context, and that is an exciting one because obviously, there's a variety of dopaminergic drugs that are used to treat ADHD, and we are definitely finding that we've had some patients that are able to start taking far less of those types of medications and even stop taking those medications as they're getting into a good groove of using the device.
And that's really exciting. And again, I know it's preliminary, but there are data showing that some of those drugs that increase dopamine, like Vyvanse, they also stimulate new nerve growth. So it would be amazing if you could study it to see long term, is this actually helping regenerate neurons?
Yeah, pretty exciting. And that is absolutely one of the angles that we're starting to look at. And again, thank you for prefacing with preliminary. We never want to get out ahead of our skis and start claiming that we know things that we don't yet. But we've got our preliminary data and we're excited about it, and we've got a process to go through to get to that point where we can go out and say, hey, we're there, we can do this.
That's awesome. Another area I'm really excited about is patients with migraines that are retractable. What is your experience for people with bad headaches in this device?
Oh, great question. So, chronic migraine, the comorbidity of chronic migraine and generalized anxiety disorder is very high. And there's a cause and an effect in every aspect of interaction is going to be the case. Anytime we're in chronic pain, anxiety is going to go up. And so, there's a lot of reasons why those things are comorbid, but they absolutely, we get quite a bit of coinciding of that. And so, catastrophizing, negative ideation, assuming the worst, iterative thinking that leads in bad outcomes is part and parcel with chronic pain disorders, right? And so that's been one of the more effective ways that really in those conditions we've been able to utilize that is helping to reframe thought. Migraine is curious because one of the main brain regions that's involved is a region called the hypothalamus, and the hypothalamus is kind of a central part of the brain that controls a lot of the unconscious functions of the brain. And even the unconscious emotional output of the brain runs in large part through the hypothalamus. It'll control parts like the autonomic nervous system, the sympathetic, parasympathetic, fight, flight, rest, and digest. That's descending control through the hypothalamus. And even our hormones are descending control down through the hypothalamus in large part. And when someone gets a migraine, that hypothalamus, it activates, we say, which basically means that it fires too much. It becomes really, really overactive. And this is so things that stimulate the hypothalamus excessively can trigger migraine in those that are prone to it. This is why when people that have migraines will know, boy, if I'm really stressed out, I'm more likely to get a migraine. And that's a very hypothalamic function. And so the chair, because it can reduce worrying and shut down errant thoughts and reduce anxiety, and some of those are some of the functional outcomes we've seen in our clinical trials. And we think that's why it has a positive effect in aiding some of the other treatments that we do for migraine.
Wow. It just leads me to think, I have many patients with POTS who have trouble sitting upright, which is also, I think some of them have hypothalamic. Are you aware, even anecdotally, anyone with POTS trying your device so far?
Yeah, great question. And in the migraine clinic, we have quite a bit of comorbidity with POTS. Because we're dealing with a lot of hypothalamic dysfunction. POTS is often a spillover of that comes in there, and so and POTS is curious for a lot of reasons, but some of the more severe cases also kind of have flattened affect and a reduction in ability to experience joy. And there's some really interesting psychological effects that come with POTS over time, right? And it really can destroy a lot of emotional interactions, even that people, relationships, not just because of the pain and discomfort, but because of the emotional disconnection that can come with it. And so, the effects on the hypothalamus and some of the circuits that go in, that is an area I think of that's definitely worth exploring.
Got it. But you don't, even anecdotally, you haven't seen any cases yet that you can talk about.
I have seen probably half a dozen that have had comorbid POTS that have used the device as well. And so that's not, 6 is not enough to make any kind of a strong commentary at this point, but positive. Certainly the outcomes are good enough that we're going to keep looking.
Well, what concerned me is with some of my POTS patients, just sitting upright for 10 minutes might be difficult, but at least the ones they were able to tolerate the device.
They were, yeah, they were. And that it's interesting, isn't it? Because I would imagine that there's some type of a spillover with the vibration and maybe even some of the vascular changes that probably come from that. And I think it's more complex than I have data to explain so far. I think more is going on than just the neurological circuit that we've been studying.
Yeah, and that's been my experience with the POTS patients, is that they normally have many comorbidities. For example, they might have Lyme disease and mold toxicity, and also parasites, as an example. It normally wasn't one simple cause underlying their condition. So,
yeah, for sure. That's it. Definitely agreed.
Awesome. Tell me more about the name Neuronova. I mean, from the Latin, it sounds like a new neuron. What does the name mean for the chair? Yeah.
Yeah, I think that is kind of the idea, right? Is, I guess, and forgive me for waxing philosophical for just a minute, but one of the great joys of and wonderful parts of life is the fact that we can change, right? We can grow, we can adapt, and there are parts of our brain that are as complex as the entire rest of the body, in their complexity. We just haven't scratched the surface. The brain really is the final frontier of the human body, and we've got parts that, the left dorsolateral prefrontal cortex, for example, it's capable of envisioning and creating almost infinite possible futures. We can create worlds without end in that part of our own brain. And I think we've all experienced pieces of this where you can lay in bed at night and you can relive a conversation you had with somebody. And you think, well, I should have said this. And then they would have said this. And back and forth it goes in your own mind. And in 30 minutes, you can live out a lifetime and some of those lifetimes end triumphantly, and others, unfortunately, end up in shame and in a ditch somewhere, and all is lost. And we our brains do these things, right, in these variety of different directions. And this circuit, this mesolimbic circuit, is a beautiful circuit in some sense, because it's the part that when it fires, it puts the brain into a state that allows it to start to perceive the world differently. And so when that neuron fires, when you get a release of that dopamine, your brain kind of goes into a state that goes, wait a minute, I need to learn something new here. There's something new. I need to make different predictions. I need to I need to become a different person. And so you hope that means I'm going to become a better person, right? But dopamine is context dependent. And so when dopamine is released, it's essential that we engage in activities that approximate what we want to be, what we're trying to become. And dopamine is a facilitator of becoming and changing and growing. And so I think that name Neuronova, that idea of new brain, new circuit, new neuron is apt when we're talking about that particular part of the brain.
That's amazing, because through therapists, EMDR, there are lots of different techniques of something called memory reconsolidation, where you can go through past traumatic experiences and then basically change the memory, change the context, change the meaning for yourself. Maybe when you're about to go to sleep, or maybe with the help of a therapist, but it's powerful. These circuits are definitely powerful.
Well, and imagine for a minute, we kind of mentioned, dopamine gets released. If we boil it down real simply, we'll say when you experience something novel, which means kind of new or unanticipated, or salient, right? Something that's kind of strong or potent. And you look at a technique like EMDR, in a very real sense, you're creating a novel and salient environment. And then you go about the process of working through some issues. And so dopamine is very involved anytime change is going to be in the picture.
That's amazing. So you've shared with us some of the current uses, and it sounds like you're not stopping. You're doing further research. We talked about a few preliminary results, but kind of what's as the head of the company, where do you see this product and technology or similar technologies headed? Again, I'm not looking for trade secrets, but I am looking kind of in your mind, where do you see your company going?
Yeah, and we'll say I'm just a scientist, right? I'm just a doc. Well, we won't call me the head of the company. We'll say I'm the one that's interested in science and medicine and healthcare and patients and things like that in that sense. And so, but I love that question too, because at the core of what we're trying to accomplish, right, it really is about trying to get at some of these problems that are so intractable. I mean, if you look at just anxiety, for example, in the last 5 years, the escalation in anxiety and mental health issues in across the world, especially here at home in the United States, it's kind of outrageous, and it's unacceptable from a healthcare standpoint that we have this kind of this secondary pandemic of mental health issues that everybody's tiptoeing around, and the solutions we've had to date they have a lot of side effects, medications and things like that. They're wonderful and they have their place and they save lives, but they also have a lot of downsides and side effects. And sometimes, the traditional ways we go about this can be methodical. They can be slow. And we obviously, I don't think anybody that's involved in these problems and is interacting with patients would disagree that we need new approaches. We need more tools in everyone's toolbox. We need more options for helping people. Like, this is part of everyone's mindset, I think, that has good intentions. And so we are very interested in finding new iterative ways to stimulate the brain. A lot of my postdoctoral work was done in neuromodulation. That was kind of the majority of that work, was trying to understand how we can use peripheral stimuli to drive alterations in the central nervous system. And so I think one of the big changes that we're hoping for is we want to really gear towards underlying causes, and let that be the base, and symptomatic care becomes the branches, right? Rather than the base and root, be symptomatic care. And then we hope that it turns into something that's more structural. And so we're interested in this being able to be available to more people. We're interested in a device that's more even portable, that can be used in someone's car and in all kinds of places. And so we're actively working on new iterations of this that will allow it to be used more broadly even.
Oh, that is so exciting. And I agree with you. The data are coming out that the rate of anxiety, certainly around college age kids, or especially female, the anxiety rates have gone on tremendously. And one of the reasons for that is I think, the increased use of social media, devices, less human interaction and more device interaction. But it's cool that we're talking now about a device that might actually be part of the solution.
Yeah, for sure. Yeah, it is. It's a fascinating. This is a very interesting time in the kind of the history of, I think, even humanity. The change in the way we interact with one another was already throwing a significant inflection point in brain development. And then we've just thrown another atomic weapon into the midst of it with artificial intelligence. And we had not even figured out the last inflection point, which was smartphones and social media. We're just at the point where we've got enough data to look back and go, whoa, what did that do to us? Like that's a problem. And now we've got legislation and all kinds of things that are starting to come out to address like what happened a decade ago. And we're not even close to getting a handle on that. And we've just thrown into the mix something that could be 100 times more potent and more of an inflection point. And so this is going to be a very curious next 5 to 10 years in the history of what happens to brain development from the time we're small to the time we're old. I think we're going to be looking at very different brain profiles in another generation than what we've measured in the previous 3.
That is fascinating. Let me ask you along those lines, one of the causes, I think, for increased anxiety is not enough downtime. And so the tie-in here, though, is maybe one of the ways the device works is for those 10 minutes, sometimes people are not doing anything else. They're disconnected from their devices. Maybe they're connected with a person, but let me ask you this. What do you recommend people do while they're using the device?
Yeah, great. I love that. So again, I'll go back to a previous comment, which is dopamine is context dependent. And so dopamine is, it's not, there's no morality to dopamine. And what I mean is it's not good or bad per se, right? Dopamine is what it is. Dopamine is a reinforcer. It's a change agent. It does those things. And so because of that, it depends very much what you do and what context you provide to a release of dopamine. And so this would be one of the reasons we would say, doom scrolling on Instagram is probably not an ideal activity for the brain, because you've got this novel, potent thing that you're looking at that's in the context of you comparing yourself to fake people. And it provides this context of irrationality, and it reinforces probably all of those insecurities that we're not really interested in reinforcing. And so the context matters quite a bit. And so we would recommend someone sits on that chair, we put that phone away. Don't look at that phone. Try to meditate, try to be still. Try to hold tight for a minute. If you want a quick way to gauge the health of some of these circuits, here's an experiment you can run at home. Get a little rock or any little device, any little object in your house that's semi-interesting, and put it on the kitchen table and sit in the chair just right in front of that little object. Let's say it's a rock, right? You go get a little rock from the garden, there it is. Try for 5 minutes to only think about that rock. And don't let your mind go to anything but the rock, and see how long it takes before your mind shifts off to some other topic. And that is a fairly good proxy for the health of the connection between that prefrontal cortex and some of these other circuits that we've been talking about. In an ideal world, you'll be able to go quite a while where you're in control of your own thoughts and you're targeting them towards something in particular, instead of you being controlled by your thoughts and them taking you wherever they want to go. You want that conscious part, that prefrontal, you want it to be able to make a decision about what your thoughts do, instead of them just turning you into the object that's getting acted upon. And so that, I think, is one powerful way that utilizing this circuit can enhance someone's ability to be in control of their own thoughts and not be a victim of their own thoughts and be just whisked around by every wind of a thought that comes into the mind, and we're just laying there dealing with it.
Wow. So for someone trying this experiment at home, how long should ideally they be able to focus on something like a rock?
Yeah, it's curious. I don't know that I know a precise time that would equate to positivity or health. But one thing I'll mention, if you can get through 5 seconds and then you can't control your thoughts, that's probably not good.
Okay.
Yeah. If you can get through a minute or 2 or 3, you're probably doing okay, right? But on a positive note, this is a habit that you can work on. Like, these are circuits that can be reinforced. And so if you can't do it, then practice it. Take that time and turn off your phone and turn off the television and go sit on your metaphorical porch and just rock and look off into the stars and have some of those quiet moments where you can just be still. There is great power in being still and being intentional about what your thoughts and your mind do. That's a form of self-control that is highly underrated in today's society.
That is powerful. And obviously you can get better the more you try, the more you practice. And this seems like the exact opposite, where they say, don't think about a pink elephant. It's like,
yeah. Yeah. It's tough, right?
Yeah.
It's tough. Well, it's invariable. You're going to be thinking about a pink elephant. Instead of don't think about a pink elephant, you got to say, think about a green elephant. Right? You got to be intentional. The brain, it doesn't work in an attempted absence. It works in an intentional filling.
Wow. So, are there any questions I should have asked you but didn't?
Oh man, that's a tough question. I guess I would reiterate just this concept that, our brain was pre-programmed, in my belief, right? There's a divine design in some of these things. And we were very much designed to become something iteratively better and to interact in that way with, for me, the divine in that sense. And it's mirrored after that echo of divine, so that we have within us, the brain was programmed this way, so that wherever we are, there's always the chance to be better and to improve. And the brain wasn't engineered such that we have to just wallow in how terrible we are, but it was engineered such that there would be some iterative ability to change and to become. And even though there's effort required in those things, it's one of the more beautiful parts of the human mind. It is a special piece of humanity that we can even just lay in bed and we can iterate and we can live and we can create and we can move towards goodness. And these parts of our brain allow us to be just a little kinder tomorrow. They allow us to work through forgiveness and moving past things that we're holding on to. And I think, that's one of the most beautiful and divine parts of the human brain is that ability.
Thank you so much. I know your team has offered our listeners 10% off. The code will be below, but it's just Dr. Josh, DRJOSH. And how can people reach you if they want to find you?
Boy, feel free to reach out. You can reach me here at the med school. I'm Kyle.Bills at norda.edu.
Awesome. And are you on social media?
Recently, I traditionally have not been, again, for all of those dopaminergic
Of
reasons
course.
that we talked about. It's never, I've been a little more comfortable at home or in the lab or the clinic. But of late, yes, I think I'm now, as of maybe a week ago, I'm on Instagram. I think it's Dr. Kyle Bills, but I'm always a little scared of Instagram and social media. So I'm working on becoming better.
That's awesome. Dr. Bills, thank you so much for sharing your expertise with us today, for helping invent such a cool device, and really for your scientific, inquisitive mind, not stopping at the first setback, but keep moving forward to help patients. I love what your company's doing, what you're doing. So I salute you.
My pleasure. Thank you for having me and engaging in a fun discussion. I appreciate you. Thanks for all you're doing.
Dr. Bills, thank you so much for a grounded, scientifically honest conversation on nervous system regulation and Alzheimer's prevention. For clinicians and patients alike, this reframes brain health not as symptom suppression, but as restoring the brain's capacity to regulate, adapt, and endure. We'll share links below to Neuronova and instructions on how to order the device if you're interested. Thank you so much for joining us. If you enjoyed this episode, please share it with someone you care about, subscribe, and click like. For a 10% discount on the device, use the code Dr. Josh, DRJOSH, on the link included in the show notes. Peace and plants.